Good afternoon, everyone. So today we'll be discussing about the analgesia part, mainly in anesthesia. So first of all, the meaning of analgesia is to get relief from pain. An means no, algesia means pain. So no pain. Before that, before knowing about analgesia, we should know something about the physiology of the pain with some terminologies. First of all, the nociception, that is detection by the nervous system for the potential for or actual tissue injury, which protects animal from painful or noxious stimuli. There may be different types of pain, or maybe physiological pain, for example, house pain, little or no tissue injury, and pathologic pain, which always follows tissue injury, and it may be acute or chronic. Coming to the pathologic pain, there are different classifications of pathological pain. Based on the mechanism, it may be inflammatory, it may be neuropathic, it may be cancer-associated pain, or some pain there may not be any reason, that is idiopathic pain. Now, based on the origin of pain, it may be visceral or somatic, that may be superficial or deep. Based on the severity of pain, it may be mild, moderate, severe, or none. So coming to the pain pathway, after getting an injury, how it is transformed to the stimuli and then it goes to the central nervous system and how the patient responds to the pain, we should know the pathway. So coming to step 1 is the transduction. What happens here is the transformation of the stimuli into sensory electrical signals, that is action potentials. From there, second steps come, that is the transmission, where the sensory impulses conducted to the spinal cord. Then these impulses are modulated. Then they are either amplified or suppressed. They may be amplified or suppressed. If it is suppressed, patient will not get any pain. If it is amplified, then patient will have pain. Lastly, the perception of the pain. Impulses that are transmitted to the brain, where they are processed and recognized, whether it is a deep pain or it is a superficial pain, it is a visceral pain or a somatic pain, that it will be perceived by the central nervous system. Each step has different receptors. So, according to the receptors, drugs can be selected that will target specific receptors and block a specific step so that the pain has been relieved. And if we are targeting different specific receptors, then it will be the multimodal therapy. That means we are using multi-drugs. For example, if we use opioids combined with NSAIDs, combined with some regional blocks, that is the multimodal therapy. In the multimodal therapy, we are targeting 2 or more of the receptors to control the pain. Now, if we don't treat the pain, then what are the consequences of that untreated pain? There may be catabolism and wasting, immune system suppression, inflammation and delayed wound healing may be there. And if analgesia is not controlled properly, then patient might need the increased doses of anesthetics, for example, muscle relaxants, inhalational agents, and ultimately the patient will suffer. Now coming to primary hyperalgesia, it is a peripheral hypersensitivity reaction. It results from tissue damage and constant stimulation of nerves. Area close to the site of tissue injury becomes more painful when stimulated with non-noxious stimuli. So everybody will be knowing the meaning of hyperalgesia. That means area close to the site of tissue injury becomes more painful when stimulated with non-noxious stimuli. That means if we are giving non-painful stimuli to a patient who is having tissue injury, but we are actually not giving any stimuli to the injured part. If we simply touch the non-injured part, patient will complain of pain. That is hyperalgesia. Secondary hyperalgesia, the central nervous system hypersensitivity or wind up. Area of hypersensitivity is further away from the site of tissue injury. It results from constant stimulation of spinal cord neurons, and these neurons becomes hyperexcitable and sensitive. Now, what are the physiological changes that are caused by the pain? So, every system is involved in pain. So, different changes in different systems will happen due to pain. In the neuroendocrine system, the changes can be a result in a catabolic state and wasting. There may be release of ACTH release, increased release of ACTH, cortisol level may be elevated, epinephrine and norepinephrine level may be elevated, and there will be decreased insulin secretion. As a result, patient will have hyperglycemia and there may be decreased wound healing and infection parameters may be more. There will be sympathetic stimulation and it can lead to cardiac arrhythmias. For example, there may be tachycardia due to pain. If pain is very severe, patient may have some other arrhythmias like ventricular tachycardia, then atrial fibrillation, atrial flutter, etc. And these cardiac arrhythmias may be a cause of vasoconstriction, increased myocardial work, and increased myocardial oxygen consumption. And it may also lead to acute myocardial infarction also. Now, what are the signs of pain in animals? Pain elicits a stress response. Stress-related pain results in fight or flight. Physiological response and avoid anthropomorphosis. Coming to preemptive analgesia. Preemptive analgesia basically means suppose a patient is undergoing operation today. Before taking him to the operation theatre, whatever analgesia we are giving before the starting of anesthesia, that is termed as preemptive analgesia. So administration of pain medication before the pain occurs commonly involves adding analgesic to pre-medication prior to anesthesia, and it reduces overall requirement of analgesia and duration of administration. It prevents wind up. There may be some behavioral responses to pain in different types of population, in different types of patients. It also varies depending on the species, age, breed, and temperament. For example, young patients are less tolerant. Cattle are very stoic. Large dog breeds more stoic than small toy breeds. Cats hide. Dogs seek honor, comfort. Herd animals separate themselves. Vary depending on nature, duration, and severity of pain. Vary on the presence or absence of humans. Physical evidence of pain. There will be changes in the gait and level of activity. For example, if patient is having an arthritic pain, patient will have difficulty in walking and the level of activity will be reduced. Reluctance to lie down or constantly shifting position. Evidence of thoracic or abdominal pain. That is, if a patient is having thoracic or abdominal pain, patient will have reluctance to lie down or they will constantly shift position from lying down, from supine to prone, or from left lateral to right lateral. Patient may express their pain by vocalization also. They may whine, growl, whimper, groan, snarl, bite their lips, hiss, grunt or purr. There may be emergence delirium, for example, post-operative immediate post-operative vocalization may be there. Patient may also changes in their facial expressions, appearance and attitude due to pain. Now, how do we assess this pain? We have different tools for pain assessment. One is verbal rating scales, one is simple descriptive scales, one is numerical rating scales. One is visual analog scale, and finally comprehensive scales. More commonly, we use numeric rating scales, verbal rating scales, and visual analog scales in our day-to-day practices. Verbal rating scales and simple descriptive scale. Patient will have tell no pain, mild pain, moderate pain, or severe pain. They will tell by themselves. Coming to pain assessment tools, in the numerical rating scales, we have categories. So there is pain score from 0 to 10, and accordingly, we have to interact with the patient, we have to see the appearance of the patient, we have to see the posture, then we have to check the cardiovascular system and the respiratory system, and accordingly, we have gradings. In all the parameters, there is scoring from 0 to 2. So accordingly, we give this scoring system from 0 to 10. If it is 0 to 3, it is mild. If it is 3 to 7, 4 to 7, it is moderate. If it is 7 to 10, it is severe. And coming to visual analog scale, it is actually a hypothetical scale. We just give a piece of paper to a patient and tell, we draw 2 lines, 2 points at the starting of the patient, which indicates patient doesn't have any pain, and at the other extreme, that is the worst possible pain that a patient has felt in his life. That is the extreme, means most severe pain in his lifetime. So patient will himself or herself put a dot in the scale so that we can assess his or her pain score. Another scoring system, we have this comprehensive scale. This is very complicated, and we have all the parameters here, visual analog scale, then we have to describe everything. Is the pain present upon admission? Actually, we have a form of this comprehensive scale. So everything we assess, what medications we have given, what medications patient has received before, what is our plan, when the patient will be discharged, what is our plan. So everything, it is a comprehensive scale. Now, how do we assess this response to therapy? So, patient might have acute surgical pain or chronic pain. Patient may have pain every hourly or every monthly. With effective analgesia, pain-associated behaviors will recede. Patient will have good appetite, grooming, body position or posture, interaction with people. With effective analgesia, pain assessment scores will decrease. Now coming to perioperative pain management, preemptive analgesia already have discussed. It begins in perioperative period with pre-medication, may be administered as part of anesthetic pre-medication. In this, we can give NSAIDs or we can give transdermal patches. For example, we can use fentanyl, which is an opioid. We can use buprenorphine pads, which is also an opioid. We can use ketorolac patch also. And multimodal therapy, I have explained what is multimodal therapy. The use of more than one drug to control pain, which cover multiple receptors and mechanism of action. Reduced dose of individual drug and anesthetic agent. Basically, we are using multimodal therapy in our day-to-day practice. If patient is having pain, he or she needs analgesia at every stage of hospitalization and treatment. These stages may be categorized as pre-anesthetic period, surgical period, immediately post-operative period, remainder of hospital stay, and after discharge at home. Choice of drugs depends on severity and type of pain, patient general condition, and route of delivery. Now basically analgesics we can classify in 2 broad categories. One is the opioid analgesics and another is the non-opioid analgesics. In opioid analgesics, all the opioids, for example morphine, fentanyl, buprenorphine, tramadol, everything comes under opioids. And non-opioids, whatever we call as NSAIDs, for example, this ketorolac, then paracetamol, COX-1, COX-2 inhibitors, all this comes under non-opioid analgesics. In anesthetic daily practices for surgery purposes, we basically use this opioid as analgesics. For example, commonly used is fentanyl and morphine. So using opioids in analgesics, they vary in potency, duration, and adverse effects may be there. Injectable premedication, they are often in combination with a tranquilizer. Then the diminished duration of action is around 2 to 4 hours, so not good for post-operative pain. So during surgery, patient is not having pain, but after surgery, once the duration of action has been gone, patient will experience pain. Then induced state of potent sedation in case of neuro-left analgesia, provide analgesia throughout surgery and for some time post-operatively. In post-operative analgesia, opioids can be used alone or in combination with other drugs. For example, we use morphine with epidural and local anesthetics. We give in the epidural catheter for relieving pain. Or else we can give morphine with some transdermal patches. We can use paracetamol, ketorolac with transdermal patches. That is basically a multimodal approach. We can use sedative and anti-anxiety drug also. All these opioids, they are having gastrointestinal effects. They may have nausea, vomiting, constipation in case of morphine. They may have ileus, they may have colic. And these drugs are mainly metabolized in the liver. So morphine, it is the basic drug in case of opioids. So it is a Schedule II drug in the United States and Narcotic Canada, used for moderate to severe visceral or somatic pain. It can be used in the pre-anesthetic period and during anesthesia. It can be used as analgesia. It is a pure agonist with affinity to mu and kappa opioid receptors. It may sometimes cause excitement or dysphoria in animals. Sometimes it causes restlessness also in animals. In human also, sometimes if the dose is overloaded, then patient might have excitement or dysphoria and patient may behave abnormally in case of morphine overdose. It can be administered IV, intramuscularly, subcutaneously, intra-articularly. It can be given in epidural space or with spinal injection in the CSF. Adverse side effects: increased gastrointestinal stimulation in dogs and cats, ileus and colic development in horses. Then there may be meiosis. Patient may have bradycardia, increased intraocular pressure and urinary retention, and sometimes there may be physical addiction in humans if patient takes continuously morphine tablets or IV injections. Sometimes these morphine tablets we are using in these cancer patients to relieve pain. Sometimes patient becomes addicted to these morphine tablets, these cancer patients. Another agent, oxymorphone. It is also a pure opioid agonist. It has greater analgesic potency and sedative effect than morphine. It has fewer side effects, but duration of action is longer than morphine. It has fewer tendencies to induce vomiting. It can be administered as IV, IM, subcutaneously or epidural, similarly as morphine, but it is expensive drug. Another opioid agent, hydromorphone, it is also an opioid agonist, but compared to oxymorphone, the potency is less, but duration of effect is similar to oxymorphone. It can be administered similarly like morphine and oxymorphone. It is less expensive than oxymorphone. Another example is this methadone. It is a synthetic opioid. Characteristics are similar to oxymorphone and hydromorphone. Chances of MS is less in case of methadone. It acts as an antagonist at the N-methyl-D-aspartate receptor. Coming to this synthetic opioid, most commonly used opioid, fentanyl. It is one of the most potent analgesics known. Onset of action is very rapid and duration of action is also short. Whenever we give IV injection of fentanyl, onset of action it occurs in 1 to 2 minutes and duration of action it lasts for around 30 to 45 minutes. If we give continuous IV or through an infusion pump, after stopping this drug, it has a very low context sensitive half time. So after stopping the infusion, after the context sensitive half time is over, patient will be conscious and oriented. It will no more be sedated. Other examples are meperidine or pethidine. They are also pure opioid agonists with less potent analgesia effect. Properties and duration of action is shorter. They can be administered subcutaneously. Margin of safety is wider. They are most commonly used as pre-anesthetic drugs in combination with atropine or espromazine. When used with a tranquilizer, it provides effective neuroleptic analgesia in puppies. Used with injectables, NSAIDs to provide analgesia before NSAIDs take effect. They falls under the Schedule 2 drugs and narcotics. Buterphanol is also a opioid. They are synthetic opioid with agonist and antagonist properties. They basically stimulate the kappa receptors and blocks mu receptor. So this buterphanol, it cannot be used along with morphine because they are mu antagonist and morphine is mu agonist. They produces less sedation, dysphoria and respiratory depression as compared to morphine. They can be used to reverse the effects of morphine and fentanyl, buterphanol. So, patients, those who are dependent on morphine and fentanyl, we used to treat with this drug, buterphanol. They are used as pre-anesthetic sedative and post-operative visceral analgesic. It can be administered IV, IM, SC, orally also. It can be given in epidural or in spinal in the CSF. They falls under the Schedule 4 drug. Another drug, it is the buprenorphine. They are partial mu agonist that produces some analgesia for mild to moderate pain. Used to provide post-operative analgesia in animals and humans, can be used to reverse the effects of morphine and fentanyl. Administered IV, IM or epidural orally to cats. delayed onset of action and longer duration of analgesia in case of buprenorphine. Used with a sedative, it can prolong sleep times. This buprenorphine is expensive than morphine. Another drug is nalbuphine. They are kappa agonist and mu antagonist with greater antagonist properties than butorphanol. They have weak analgesic property and sedative properties. They are sometimes used as a reversal agent for opioid agonist. For example, morphine dependency can be reversed by nalbuphine. They can be administered IM, subcutaneous, injections repeated as necessary as per the duration of action. Despite disadvantages are shorter duration of action and potential adverse reactions may be respiratory depression, bradycardia, excitement, apprehension, hypersalivation may be there. Patient may have mydriasis, excessive sedation, urinary retention, gastrointestinal effects, and increased sensitivity to sound. We can also give these more opioids as intravenous infusion. For example, most commonly used infusion for intravenously opioids are fentanyl. It provides continuous analgesia for constant unremitting pain. So basically we give initial loading dose given to effect followed by same dose given over 4 hours through constant flow. Drug may be added to a bag of fluids if an automated infusion pump is not available. We have to monitor the patient frequently for adequate pain control, excessive sedation, or any other adverse effects are there, then we have to decrease the dose, and if needed, we have to reverse it. We have to adjust the rate of administration according to the patient response. Morphine, for example, can be administered with lidocaine, which is a local anesthetic, or ketamine to control severe pain. Sometimes we use these opioids intra-articularly also. Suppose patient is having some joint replacement surgery or some arthroscopic surgeries in the joints, for example knee joints, ankle joints, shoulder joints. These opioids are injected in the intra-articular space, and this provides a very good post-operative analgesia to the patients. This analgesia usually lasts for 8 to 10 hours, but if we use 1 or 2 drugs, we can make it up to 18 to 24 hours. Patient will have no pain after surgery. Opioids can be used as an epidural injection. What we do is we instill opioid into the epidural space at the lumbosacral junction. It provides analgesia to hind limbs, abdomen, thoracic cavity, pelvis. Morphine is the most commonly used opioid in case of epidural injections. It may be combined with an alpha-2 agonist in large animals. Profound postoperative analgesia with long duration of action. Suppose we are using morphine in the epidural, patient will not have pain for around 24 to 48 hours if adequate dose has been given. Similarly, as morphine, we can use fentanyl also, and these opioids we can give to the patients as continuous infusion also, or you can give as a top-up doses. Instillation of an opioid into the epidural space at the lumbosacral junction. They are usually administered after induction of anesthesia but before surgical procedure begins. If we are using regional anesthesia, then we are using only this epidural with spinal. If we are giving general anesthesia, then sometimes we put the epidural catheter before induction of anesthesia, but the drug, basically the opioids, we wish to give before the surgical incision. Onset of action is around 20 to 60 minutes. Duration of action is around 6 to 24 hours. It may increase if we use some other additives. It must be supplemented with general anesthesia for surgical procedures. For example, if we are doing surgery in the thoracic cavity or with the abdominal cavity, these epidural opioids we have to supplement along with paracetamol, ketorolac, and other NSAIDs. We have to reposition all the patients every 2 to 4 hours to prevent pulmonary atelectasis or prolonged pressure on the superficial nerves. Now opioids, those opioids which are lipid soluble. This is very important. Lipid soluble opioids, they also comes in the form of transdermal patches. For example, fentanyl, buprenorphine patches, then other NSAIDs like diclofenac also it comes as transdermal patches, and ketodolac also comes as transdermal patches. But morphine doesn't come as transdermal patch because it is not lipid soluble. Fentanyl transdermal patch, it is a reservoir of fentanyl enclosed in plastic, attached to clip skin and left in place for several days. It comes in various sizes, 25 microgram per hour. It will release at a fixed dose, 25 microgram per hour or 50 microgram per hour, 75 or 100 microgram per hour. It will keep on releasing. If the size of the patient is huge, then according to the dose, patient might require one or more patches. They provide convenient long-term opioid administration, similar to IM oxymorphine injection, but longer duration of action, delay of action from 4 to 12 hours or 12 to 24 hours as drug is absorbed through the skin. For example, if we are using a buprenorphine patch or a fentanyl patch to a patient, suppose we have applied just now, effect will not come immediately. It will take time, around 4 to 12 hours, or it may take around 18 to 24 hours. Apply patch at least 6 to 12 hours prior to the start of surgery. So, these patches are used as a preemptive analgesics. For example, some patients are going these cardiac surgeries, thoracotomy is being done, or some exploratory laparotomy is being done, planned for tomorrow. So today only, before 12 hours, we will apply these patches so that before the surgery starts, this analgesics starts working. Supplement with another opioid or NSAID if patch is not applied until after surgery. Fentanyl pads provide analgesia for postoperative pain and pain associated with trauma, burns, cancer, and painful abdominal conditions. Amount of drug absorbed through skin varies among animals. Monitor for breakthrough pain and supplement as necessary. We have to also monitor for fentanyl overdose. For example, if patient is having overdose of fentanyl, patient might have gait disorders, they might be disoriented and dysphoric. So in that case, we have to remove the pads accordingly. Another important thing is that heat may increase the amount of fentanyl absorbed. So we have to keep the fentanyl pads in such an area where there is no heat generation or it doesn't come in contact with sunlight and all. So if patient is having high fever or amount of fentanyl absorbed will be increased, and we have to also avoid contact of patch with external sources of heat, for example hot water bottles, heaters, blowers, etc. Now coming to non-steroidal anti-inflammatory drugs, they are mainly this acetaminophen, meloxicam, ketoprofen, etodolac, aspirin, all these things are NSAIDs. The mechanism of action of NSAIDs, efficacy, it's like somatic and visceral pain. It varies by drugs. Onset of action is usually moderate, 30 to 60 minutes. Duration of effect varies with the species. Toxicity also varies with the species. Analgesic and anti-inflammatory properties vary by drug. They basically inhibit the prostaglandin synthesis by inactivating the cyclooxygenase isoenzymes. Some are COX-1 and some are other COX-2 inhibitors. They are basically metabolized in the liver eliminated by the kidneys and the GI tract. Adverse effects of NSAIDs. They prevent the production of beneficial prostaglandins along with the production of prostaglandins that mediate pain, inflammation and fever. NSAIDs that inhibit the COX-2 enzyme but not the COX-1 enzyme produce the least adverse effects. The perfect NSAID is not available yet. So for safe side, we are using basically this paracetamol. We are avoiding this diclofenac, ketorolacanol. Adverse effects may vary with the drug, species, breed, and individual. They may cause stomach ulcers, vomiting, gastrointestinal bleeding, and also they may cause lack of appetite. So basically, if they are using NSAIDs and analgesic, they give supplements with these proton pump inhibitors or H2 blockers to suppress the acidity, which causes stomach ulcers. Gastrointestinal ulceration leading to hemorrhage. They might also have upper GI bleed. Renal toxicity may be there because they are basically excreted by the kidneys. Impaired platelet aggregation leading to prolonged bleeding time if patient is using aspirin for a longer time on a higher doses. Since metabolism occurs in the liver mainly, liver damage may be there in case of overdoses. Antagonists to several drugs prescribed for cardiac disease and hypertension. These all are the side effects of NSAIDs. Other analgesic agents, for example, opioids or NSAIDs are the most commonly used analgesics. We can use local anesthetics like lignocaine, bupivacaine, ropivacaine, alpha-2 adrenergic agonist, and sometimes ketamine are also used as an analgesic in special circumstances. Suppose all the analgesics we have used and patient is not getting relief from pain. In extreme cases, sometimes we use this ketamine. It acts both as a analgesics and also a sedative. So basically, analgesics, we use this multimodal approach. We don't use only single analgesic. We combine the opioid and NSAIDs. Sometimes we use local anesthetics also. Sometimes we use this ketamine also. So always multimodal approach is better in controlling pain. Local anesthetics as analgesics you can use. What I said is lignocaine, ropivacaine, bupivacaine we can use as analgesics. But in that case, the concentration of the drug, the preparation of the drug will vary. Suppose bupivacaine, if we use at a dose of 0.5%, it will provide anesthesia. And similarly, if the same drug is used in a dose of 0.25%, concentration of 0.25%, it will act as analgesia. Then similarly, ropivacaine also, if the concentration is high, like 0.5% or 7.5% or 5%, then it will act as anesthesia. If we use 0.2% or 0.25%, it will act as analgesia. So they are used to prevent or treat postoperative pain. They can be used as sprayed or it can be injected at the site of injury or surgical site or infiltrated around a nerve supplying the affected area. It desensitizes the entire region. Epidural or IV infusion can also be used. Advantages of local anesthetics as analgesics are complete anesthesia of affected area, low toxicity, rapid onset of action. Because metabolism, this liver and kidney doesn't come into role. Disadvantages are short duration of action, CNS and cardiac toxicity with repeated use. So there are sometimes, if the dose is very higher, there may be local anesthetic systemic toxicity. Basically, it affects the CNS and the cardiac system. Coming to this alpha 2 adrenoreceptor agonist and analgesics, they have limited use because of their short duration of analgesic effect, profound sedative effect. Adverse effects will be respiratory depression, vomiting, bradycardia, sometimes heart blocks are also there. When used in low doses may potentiate opioid effects and increase equality of postoperative analgesia. They are basically used by the epidural route along with some other local anesthetics. This alpha 2 adrenoreceptor agonist, they are used in animals to provide analgesia and sedation also. If doses are given very high, it may also causes these adverse side effects like hypotension, then respiratory effects. Patient may have respiratory depression, bradycardia, heart block might also be there. So basically, this alpha 2 adrenoreceptor agonists, they are used only with local anesthetics to reduce pain with epidurals only. Ketamine as an analgesic, used as an adjunct to more potent analgesics, opioids, local anesthetics, alpha 2 agonist. They does not produce analgesia by itself. There is some cocktail called morphine, lidocaine, ketamine, MLK cocktail. They provides intraoperative analgesia. This ketamine, they basically blocks the N-methyl D-aspartate at the level of the spinal cord to prevent wind up. This anesthetic dose of ketamine is very high, but analgesic dose is very low. The dose of ketamine as analgesic is 0.25 to 0.5 mg per kg, but if we use as an anesthetic induction agent, the dose is 2 to 3 mg per kg. Adverse effect of ketamine as analgesic, it depends upon the dose, how much you have given. Patient basically have tachycardia, increased secretion, hypertension may be there, intraocular pressure sometimes increases, intracranial pressure also increases if we give ketamine, intra-abdominal pressure also increases if we give ketamine. And after giving ketamine, when the patient wakes up, patient might have delirium and it also causes dissociative hallucination. Sometimes we use these corticosteroids also as an analgesic because they are having a strong anti-inflammatory properties. We use this Dexona or hydrocortisone or this methylprednisolone or prednisolone. For example, in case of this osteoarthritis, ankylosing spondylitis, then rheumatoid arthritis, along with other drugs, we use these corticosteroids also. The decreased prostaglandin activities such as NSAIDs don't use concurrently with NSAIDs. Adverse effects, they are basically ulcerogenic, immunosuppression may happen with long-term use and hyperadrenocorticism. Sometimes we use this drug tramadol as an analgesic. It is non-opiate drug with activity at the mu receptor. Also inhibits reuptake of norepinephrine and serotonin. Tramadol comes as a tablet form also or injectable form also. We can give IM also, IV also. We have to avoid using tramadol concurrently with norepinephrine or serotonin reuptake inhibitors, for example, amitriptyline. Lastly, tranquilizers and analgesia. Tranquilizers are not considered analgesics. They may potentiate effects of opioids in anxious patients. It is useful in calming the excitement sometimes seen in cats and horses or other wild animals following opioid administration. It cannot be substituted for opioids or other analgesic agents. So if we are using tranquilizers alone, patient will be calmed, patient will be sedated, but pain will be there. So tranquilizers we are using along with opiates to relieve from pain. Multimodal therapy use of more than one type of analgesic to relieve pain because, as we know, pain is produced by several mechanisms and the pathway is very long. So, if we use multimodal analgesia, different drugs will target different mechanisms along the pain pathway and patient is relieved from the pain. Examples of multimodal therapy: acetaminophen and codeine, oral treatment for moderate to severe pain in animals. Fentanyl and meloxicam we can use. Morphine and injectable NSAIDs, MLK, morphine, lignocaine and ketamine we can use as a cocktail. It is administered in IV fluids during surgery, decreases amount of inhalant anesthetic needed. So if we use this multimodal therapy, the amount of inhalational agents, amount of muscle relaxants during anesthesia, it is decreased. Home analgesia. Suppose a patient is discharged from the hospital, and what are the modalities you can use? We can use these patches, we can give NSAIDs in the form of tablets, we can give oral morphine, and we can give tramadol tablets. And nursing care, finally, relieving patient discomfort will help pain control. So keep the patient and cage or stall clean and dry, comfortable bedding, quiet surroundings, opportunity to urinate and defecate, comfortable position. So what you do is every 2 to 3 hours we change the position. Reduce anxiety with toy or blanket from home. Ophthalmic ointment in unconscious patients to prevent corneal drying. Comforting reassurance through touch and talking. Non-pharmacologic therapies for pain. It is used in conjunction with or as an adjunct to pharmacological therapy such as acupuncture, TENS, transcutaneous electric nerve stimulation, massage therapy, cold and heat application, physiotherapy, laser or magnetic therapy, homeopathic or herbal remedies. So this is all about analgesics. Thank you.